Hello friends, this is a case of laparoscopic Boari flap repair. Actually, laparoscopic excision of massive pelvic endometriosis was done by me. At the same time, right-sided ureteric reimplantation was done because of distal ureteric stenosis with reduced renal function. DJ stents were placed on both sides. 3 weeks after operation, left-sided DJ stent was removed. 1 week after removal of left-sided DJ stent, patient came to me with history of dribbling of urine. IVP and CT urogram showed ureterovaginal fistula on left side. I reviewed the recording. This fistula formation was due to malhandling of ureter and heat spread. I counseled the patient and the party. I planned for second operation by laparoscopy. Patient was placed in dorsal lithotomy position and Trendelenburg position. One 10 mm supra-umbilical port and 3 5 mm ancillary ports were placed. Among 3 5 mm ancillary ports, one was placed suprapubically and 2 were placed on both sides. Left one was placed at slightly higher level than right one. I examined the pelvis after entering inside abdomen. There was too much bladder adhesion. Too much bladder mobilization was not possible on left side because of previous right-sided ureteric reimplantation with psoas hitch. So I decided for psoas hitch and Boari flap on left side for tension-free anastomosis between bladder and ureter. Because of previous laparoscopy, there was massive pelvic adhesion. Adhesinolysis was done. At first, sigmoid mobilization was done. Harmonic is better. You may use shearer also. For flimsy adhesion, it is better to use pulling force. Little bit ultra dissection, then sigmoid flipping. External iliac vessels were exposed. Further dissection was done. Further sigmoid mobilization. It is better to use gauze piece for mopping. Stump of infundibulopelvic ligament was exposed. Then I dissected the bladder at space of radius on ipsilateral and contralateral side. That is called bladder dropping. Silvery structure was Cooper's ligament. Because of previous surgery, there was dense adhesion. So I dissected the bladder cautiously to avoid unnecessary injury. There are so many delicate veins. Avoided injury to them. Otherwise, there would be unexpected bleeding, which would soil the operation field. I checked the mobility of bladder. Psoas muscle was dissected. Peritoneum overlying it was removed. I returned back to the point where I started. The stump of infundibulopelvic ligament was dissected. I took care of the external iliac vessels. Ureter was exposed. It was densely adherent to external iliac vessels. Ureter was separated from the external iliac vein. Separation was done with Maryland forceps and a blunt instrument, that is Babcock forceps. See the procedure. Push the tip of Maryland, open it, counter traction by blunt instrument. Note the stricture with proximal hydroureter. I transected the stricture portion of ureter. I ligated the distal end with vicryl. You may use clip also. Further bladder mobilization, separation of the bladder from rectum. I checked the length deficit. I removed previous degestant. I measured the length deficit again. Marking was done for the bladder flap with monopolar hook. Base should be at least 4 cm. Apex should be wider. Length of the bladder flap will be slightly larger for tension-free anastomosis. Tongue-shaped bladder flap was made. It is called neocystostomy. Flap length will be up to healthy ureter end. I used harmonic for cutting the bladder. You may use cold scissors also. You should maintain the ratio. Length is wider, maximum 3:1 to maintain adequate vascularity. To avoid ischemia in the implantation area, you may take curve flap also for extra length. See urine coming out. Spatulation was done at healthy end of ureter. This is to create wider opening and to avoid stricture. First I did partial anastomosis between ureter and the bladder flap. That is posterior wall of ureter with bladder flap. I fixed the anastomosis by giving stay suture at 6 o'clock and 12 o'clock position. I gave interrupted stitches, used 20 vicryl, through and through bites. Stitching fashion was outside in, inside out. There was no kinking of ureter. I did tension-free anastomosis. No need of tunneling, as reflux of urine is very rare in adult. So I did direct anastomosis. 2 to 3 stay sutures were given over bladder flap to maintain cylindrical figure. Digestant was placed by laparoscopy using metal sucker. Further mobilization of bladder. Then I started bladder closure in single layer with 20 vicryl, taking continuous stitches. You may use V-lock suture for better tension. You may deconstruct the bladder in double layer also. Then I made a cylindrical structure from the bladder flap, giving continuous stitches. Here stent acted as guide to maintain patency. Note bleeding from bladder flap, that means adequate vascularity. Also, psoas stitching was done to reduce tension. Then I completed the anastomosis by giving circumferential stitches. I did methylene blue test to check the integrity of bladder. A drain was placed in the pelvis. It should be removed when daily drainage less than 50 ml. Polish catheter was placed for 3 weeks. DJ stent was kept for 6 weeks. During stent removal, always do a cystoscopy. You may face following complications after Boari flap: nocturia, urgency, urinary incontinence, that is urge incontinence due to reduced bladder capacity, hydronephrosis, although spontaneous resolution is possible because of disappearance of postoperative edema, stricture ureter, UTI, urinoma. Remember, laparoscopic Boari flap is minimally invasive procedure to reconstruct the ureter when there is long segment stricture or defect in mid ureter. Long defect means 8 to 12 centimeter defect. This is for creating a flap from bladder wall to lengthen the ureter and then attaching the shortened ureter to the bladder flap by making it cylindrical. This is to restore urinary flow. Boari flap can bridge up 15 cm of defective ureter. In case of psoas stitch, it is 10 cm. Advantages of laparoscopic repair: less blood loss, faster recovery, better cosmetic value, shorter hospital stay, less chances of infection, less analgesic requirement, less chances of incisional hernia. Thank you for watching this video. Don't forget to subscribe my channel and press the bell icon for further updates. Have a nice day.